Hi, everyone. My name is Dr. Helen O'Neill, and I am CEO and founder of Fertility Health. I'm also a molecular geneticist, so my background is in human reproduction, where I've specialized in human reproduction and reproductive medicine for the last 9 years as a lecturer in reproductive and molecular genetics at University College London. So why that matters is that I've essentially spent the last 16 years in research and education and in really trying to better understand human reproductive anatomy, physiology, all of the ways that we can reproduce. And what was really difficult for me was going through a personal journey, thinking, irrespective of all of the people that I'm trying to teach. So I lecture masters and medical students about fertility, infertility, reproductive anatomy, pretty much all of the factors involved in human reproduction, and I had no idea about my own body, about my own fertility, about my own limitations. And there's a real strange irony in being a so-called expert, but being quite ignorant in your own body. And despite having an access, to world-leading experts, despite these being my colleagues, despite working with IVF clinics, working with eggs and embryos, and despite the NHS, there still was no real option for me. And so that was something that I felt quite lacking in any conversation I had when people would ask me about what their options were. I actually felt a little bit helpless because there was nowhere I could really send them that wasn't either a dead end in very many cases, and I'll explain why, through the NHS. Despite it being amazing, it doesn't necessarily cater to many fertility journeys, certainly not same sex. And the private option, which is a complete barrier to entry, both in terms of your psychological barrier to entry, because it can be quite daunting entering into an infertility clinic if you just want to know where you're at. But also the major barrier was this financial barrier to entry. So we've spent the last 4 years essentially creating something that could translate all of the research that we know, all of the practices that are done in a clinic, and bring it into an at-home solution. So that is what essentially we created Hertility to do, was to enable people to better understand their bodies, but also to make babies, and to be able to investigate the why if they're not able to do so. So I'm just going to share some slides with you here. I'm not sure. I think there is a Q&A function, so I'll try to get to the Q&A function at the end. Please bear in mind I can't see any questions coming through because while I'm sharing screen, I won't be able to see anything. So, right. It all starts with a trigger warning, because I'm going to be covering subjects related to fertility and infertility, pregnancy, baby loss. So I really hope that if this session is difficult for you, you'll be able to pause and come back. We're recording it and we'll be able to send it out. We also have a fertility counsellor and a really amazing and caring team should you wish to ask any further questions following the webinar. So we're just going to discuss how to get pregnant in a same-sex relationship. And I want to start with the fact that there are actually really many permeations of how we can do this. And sometimes we can just, because of the lack of provision of services and especially catered to same-sex relationships, and because of the lack of success or the difficulty in the very convoluted pathways, we can often be quite negative about it. And I think as a reproductive geneticist and scientist who's worked in embryology for so many years, I first just want to say that the fact that we can do this at all is pretty astonishing. The fact that we can create life outside of our bodies, the fact that we can procure gametes, sperm and egg, fertilize them and then transfer them irrespective of the genetic origin, I think is quite astounding. And I just want to take a moment for that because I think, for IVF has essentially only been around for 40 years, which seems like a long time, but there have been generations of people who've just not been able to fulfill their family goals. So I just wanted to take a moment to take an ode to the science before we get into the nitty gritty. So firstly, I wanted to also highlight that we are really creating a full system of care at Hertility. So for those of you who don't know how Hertility works, as I mentioned, we wanted to create a scientific triage that enabled us to better understand our bodies. And we do this through an online health assessment. So you go to Hertility, You fill out a very comprehensive health assessment where we've asked all of the relevant questions related to your reproductive health. We'll then send you a test that will arrive at your house. That test is tailored to you based on the answers that you've told us. So based on the combinations of symptoms, menstrual patterns, lifestyle factors that could be indicative of any one of 18 pathologies, we'll test. You do that blood test. It's a small capillary, which is a finger prick blood test, and then you send it off to our labs. So you'll get a really comprehensive personalized blood result or test result that goes through every hormone, why we tested it, what it means for you. But moreover, rather than just providing blood results, we're actually providing answers. So we've really interpreted all of the different variations between symptoms, menstrual patterns, and what the hormones mean. And we've taken a very long time and have been very dedicated to making sure that this isn't obstructively clinical. In fact, that it's not already clinical at all. And I think you'll probably get a feel from that with our language, that we're trying to make this as personal as possible. At the end of the day, we built this for ourselves and our friends and our sisters and our mums and our aunts. So within that report, you'll have all of the actionable insights as well relating to your results. But moreover, you have the ability to book a tele-consultation with either a fertility expert that specializes in any form of reproductive medicine or a fertility advisor. And then we will refer you through our pathways to either egg freezing fertility treatment or an ultrasound scan should you need it. I really firmly believe that sometimes it's just nice to know that other people are going through the same thing as you. So please do lean on the community that we've built as well around this. I'm mentioning training and policy, education and awareness, because I know so many of us go through these journeys and the predominant amount of time we spend in our lives is in work. And if you have an unsupportive manager or unsupportive workplace, or you feel like you're hiding going through fertility treatment, it can make things very difficult. So if you want to highlight your organization, if you wanted to do it anonymously, that we can contact your organization about training and policy and education and awareness around same-sex family forming, LGBTQIA+, any of those things. We really do take pride in the fact that we really like to educate as much as we can around this to make people better understand the circumstances that 1 in 6 people could be going through. So if you haven't seen our same-sex guide to getting pregnant, please do check it out. We only launched it a few days ago and we've already had 600 people download our guide, which is testament to the fact that this is very much needed, but it is, if nothing else, beautiful. And we've taken a lot of time to go through all of the different ways that all of it essentially step-by-step fashion to creating a baby. So essentially inside the guide, we do just a basics for your fertility and reproductive health, sperm donation 101. Everything will be in much more detail in this guide, but hopefully I can add some color to it this evening. And then some of the fertility treatment options. There's a lovely section on fertility optimizing nutrition. And you can also book in with our fertility nurse, Emily, who's wonderful, to talk more about how you can improve your chances. And then we have some incredible case studies and stories of people who've shared their journeys with us. So do check some of those out. Sometimes a story or a journey comes alive when it's an actual personal journey. So I mentioned I am a lecturer in reproductive and molecular genetics, so I am teaching you like you're my students. So I will tell you there is an agenda for tonight, so that you know that when you watch this, you know the bits we're going to cover, that we're going to come back to, knowing that you're going to have this guide that you can download as well, just to refer back to. So tonight we're going to be covering an overview. Obviously, I can't ask you questions, you can ask me questions, so you're not really my students, but hopefully you'll learn. An overview of the fertility treatment options, an intro to IVF and essentially how it structures and it works across all different family forming units, and how to afford fertility treatment. So just some of the prices, will help you with finding a clinic and some takeaways for your workplace too. So if you learn nothing else tonight other than these 3 steps, it is that number 1, you should check in on your fertility, whoever is going to be the partner within your relationship who is going to carry, or maybe it's that you guys are going to both stimulate and swap eggs. We'll get to all of that, but regardless, you should check in on your fertility, because when we have a system in place which relies sometimes just transferring of sperm, you really want to make sure that everything is working and in good order. And so much of that we're in the dark about. Many people actually are on hormonal contraception, especially if they are experiencing symptoms, so not for contraceptive reasons. And the second part, we'll need to, I don't know why we've put get your hands on some sperm. It makes me feel wrong even just saying that, but we do need to get some sperm. And then the planned conception is something that is a really good conversation around whether you're going to use IUI, IVF. Yes, we've said WTF, but we'll explain what all of these, or I'll explain what all of these things are this evening. Okay, so getting started, the reason we really feel positively and so strongly about proactive hormone testing is the fact that obviously knowledge is power, but so many people come to us trying different options. And when we look at their ovarian reserve or their fertility or their hormones, sometimes it can be just one hormone out of range. And in fact, we really see a high prevalence of hormone imbalance, irrespective of your desire to have babies. The number one prescribed drug in the world is thyroxine, which is for thyroid imbalance. So the number one prescribed drug in the world is for hormone imbalance. And actually, this is reflected in our data, whereby of everyone who's ever done a test with Hertility, regardless of their background or orientation, at least 61% have at least one out of range hormone. So it really is worthwhile checking in just to know that you're your best self, because we give advice on what you can do to balance your hormones too. Proactive hormone testing also gives us insights into our preconception health. So many people enter a fertility journey thinking that the fun stops when they get pregnant and that they need to give up on alcohol, drugs, smoking, whatever it is, as soon as they get pregnant. And the reality is you need to do that much further in advance. And I compare it to, I compare getting pregnant to running a marathon. You would never rock up to a marathon and just be like, I'm ready, let's go, and expect to get through it. We really do need to prepare our bodies, not only for the getting pregnant part, but the getting through the pregnancy part too. So I really couldn't advise investing in your body as this vessel before you embark on this journey, not least of which for your mental health, because it can be quite an arduous journey in terms of your mental health. Also, your views might change if one or other of you has decided to go first or at the same time, or you are both deciding, I guess, the order of events, who is going to carry the pregnancy if you're doing it sequentially as opposed to at the same time. Your views might change depending on what your results say. So you might say, I actually have more time than I thought. Maybe you can go first, or I might have less time than I thought, and maybe I need to go first, or at least maybe I need to freeze my eggs in preparation, because it might be a few years before you're going to be going through this journey again for baby number 2. And also the sheer prevalence of reproductive health conditions, PCOS, endometriosis, they affect 1 in 10. And PCOS is the most common metabolic condition there is in women, and it affects our ovulation and many other things. So it is really good to just check in on your reproductive health before embarking on this journey. There are other things that you have to look at outside of your hormones and your symptoms and any of this. Every journey starts with checking in on your fertility, because you might actually have issues with ovulation, poor egg reserve or ovarian reserve, blocked fallopian tubes, and structural problems with the uterus. And when we're relying on essentially transferring sperm, either through intrauterine insemination or through donation, and you aren't aware of some of the anatomical things like potentially blocked fallopian tubes or potentially structural problems with the uterus, you're not giving yourself, that's an expensive, intrauterine insemination is expensive to go through. So making sure, and you'd have a scan with it, but it's just really important to make sure that you think of both the hormonal side of things, but also the structural side of things in terms of your fertility. Okay. There are 11 different listed causes of female infertility. And I know I'm starting with an infertility rant here, but 1 in 6 individuals are infertile. And so we see a huge prevalence. Despite the fact that there are 11 different causes of female infertility as listed on the National Institute for Health website, the number one cause, or the most predominant cause that we see, is age. So quite simply, our age declines as we get older, so much so that actually very few people realize that around 86% of your egg reserve is gone by the time you're 30 years old. Now, we start with an enormous egg reserve, and we are born with all the eggs we'll ever have. So this declines quite steadily over time. But it's really important to note that our age does play a significant role in our fertility, irrespective of anything else. And that's why one of many of the different hormones that we test is called anti-Müllerian hormone, and this is essentially a marker of your ovarian reserve. Now, AMH, or anti-Müllerian hormone, is a very good surrogate marker for your fertility, because some clinics will only measure AMH. We never measure just AMH. The reason being, we know that it's never just a marker of your ovarian reserve. I just mentioned the structural things that you should look at through a scan. I just mentioned all of the other hormones that could be out of range and any of the other symptoms that need to be taken into account. But I'm just explaining to you what AMH is, because sometimes it's the buzzword that goes around when people are talking about fertility treatment, because the first thing is they'll get an AMH test. AMH testing can be very expensive in a clinic. So just a side note to say, don't do it. Start with a fertility test. We test upwards of 10 hormones, depending on your combination of symptoms and if you have a suspected diagnosis, but we test up to 10 hormones for £149 or 199 euros. And some clinics will charge over £230 just for AMH. So when I say we've gone to great lengths to make this affordable and accessible, I really do mean it. So even if you have friends who just want to check in on their fertility, let them know that this is a much more affordable way of doing it than going privately into a clinic. I'll be killed by the clinics for saying that, but there you go. We'll still see you at some point for your journey if you're going to go through the assisted conception route. So essentially, anti-Müllerian hormone, I'm going to constantly refer to my ovaries. For every egg that's in your ovaries, it is secreting this hormone called anti-Müllerian hormone, and it's essentially the immature follicles, or would-be eggs, that are growing and maturing in your ovaries. And so if every single one of those presumptive eggs is secreting this hormone, then when we measure the amount in the bloodstream, it gives us a really good indicator for how many eggs you have, or your overall ovarian reserve, with the caveat that obviously there are other things that impact your fertility. So really high levels could mean that you're very, very fertile, but not usually. Extremely high levels indicate polycystic ovarian syndrome, or PCOS, or just polycystic ovaries. So in other words, when we say polycystic ovaries, really we just mean that your ovaries have a lot of follicles, but not necessarily many of them will actually go on to mature, and you can have irregular cycles. So naturally, if you have a lot of these follicles, you're going to have much higher levels of AMH. So it's a really good indicator for PCOS. But then low levels are quite predictive of lower ovarian reserve or premature ovarian insufficiency. Premature ovarian insufficiency affects 1 in 100. And it's essentially when you go into kind of early menopause, essentially, because you have really low ovarian reserve at a much younger age. And it affects 1 in 100, which is actually a significant number of people. And when people are young and seemingly fit and they look well, despite presenting with all of the symptoms indicative of this condition, very rarely are they actually appropriately tested for it. So oftentimes people really don't realize. Okay, I'll move on. So just one stop on the menstrual cycle. This is the graph that everybody is shown in school, and it makes no sense to anybody, but I want you to bear with me on how it does make sense. The reason is because when we go through any stimulation cycle or IVF cycle, or even a non-stimulated IVF or a non-stimulated cycle for fertility treatment, you're going to need to get down to basics, which is knowing when you're menstruating, which most of us have a clear indicator of when we bleed, knowing your follicular phase, when you ovulate, and your luteal phase. Frankly, everyone should really know these anyway, because our hormones are doing such significantly different things to our bodies at any one time that you can actually be quite forgiving of yourself for being tired, confused, or low in energy. But you could also really harness when you're high in energy, when you have higher estrogen. But essentially what we're trying to do with any egg freezing cycle or retrieval of eggs or transfer or insemination of sperm is we're mimicking the time that you need to be doing it, right? We're either amplifying this so that we're getting through a stimulation cycle so you get as many eggs as possible, or we're mimicking this so we know that we can try and get pregnant. So back to basics. the key hormones that we're talking about, and these are going to be the hormones that are given to you in a stimulation cycle through IVF, are follicle stimulating hormone. We have to mention estrogen, luteinizing hormone, and progesterone. All of them play key roles throughout your cycle. And what we see really here is that everyone talks about the time of the month being menstruation. That's when you bleed, but really the time of the month is when you ovulate. That really is the time of the month that everyone should be focusing on, because it's actually when you're at peak fertility, your concentration is highest, your estrogen is highest, your confidence is highest. You really should optimize ovulation. But then obviously it stands to reason that progesterone, if you break it down, progestation, so that's helping you get pregnant, that is the hormone that regulates the lining of our uterus, so that to prepare for implantation of an embryo. So really taking time to just say, right, at the early stage when you're bleeding menstruation, we ask you to test on the 3rd day of your period, day 3. And the reason we do is because if you look right here, all of your hormones are kind of at a base level. So they're not kind of going into crazy town here in the middle. And it gives us a clearer idea of what your hormones are. So it's very important when you do your fertility test or your blood test that you do it on the 3rd day of bleeding, so that you get a picture of this. And then moving on from there, you'll see this real increase in all of your hormones, and most notably estrogen, as the egg is released at ovulation. So all throughout this follicular phase, which is essentially when the follicles are getting ready, that's actually a really important time for your body to, that you harness that time. If you think your body is preparing something, it's preparing, maturing that egg for release at ovulation, then what you put into your body really does matter. And this was shown in a very big study where it looked at conception rates in individuals who drank a lot of alcohol or drank alcohol at all during the follicular phase, when they're getting ready, versus their luteal phase. So it stands to reason that when our body is preparing, we should give it our best possible chance. It's when we're nurturing that egg pre-ovulation. And then obviously it is only in those days around day 14, naturally enough, this assumes a 28-day cycle. The majority of us do not have a 28-day cycle. It's really important that you recognize your own ovulation anyway, but if you're going through assisted reproduction, that will be triggered for you. But that there is only that short window whereby you can get pregnant. It's amazing how few people don't actually really learn any of that until they absolutely have to, or until things aren't working out for them. Okay. So I'll start with an introduction to fertility treatments. And essentially what we're all remembering is the same steps. It's going to be pre-treatment, ovarian stimulation, egg retrieval or collection, sperm collection, fertilization, and embryo transfer. Okay, each of those things are necessary. I guess what we all have to remember is, in order for any successful pregnancy, we need a healthy egg and healthy sperm. We need them to fertilize. We need to transfer it and hope that it implants for pregnancy. Okay, with IVF, everything is being done pre-implantation or outside of the body. In vitro literally means in glass. So in vitro fertilization, that we fertilize that egg in glass. Interesting fact, the egg is the largest cell in the body, just saying, and the sperm is the smallest cell in the body. Just saying. Okay, we do need a number of things. We carry, we've got the eggs, but we do need some sperm. So essentially, for sperm donation, there's 2 types of donation. Obviously, we have egg donation and sperm donation. Why this matters is because if you have low ovarian reserve, or you are planning to essentially use each other's eggs, we'll talk about that in a minute. But if you have low ovarian reserve, it might be that you have to look into getting a donor egg. Irrespective of any cycle, we're going to need some sperm. Now, you can go through fertility treatment and get a friend, a partner, a relative to donate their sperm for you, or you can obviously go to a clinic or a sperm bank, whereby it will be screened for any genetic conditions or sexually transmitted infections. So the donor will provide repeat donations of their sperm or eggs, or their sperm, for a period of 3 to 6 months, and then they're passed on to the couple. So many couples, when you're going through this journey, that step 1 of selecting sperm can be quite Quite a lot, actually, because it's a huge decision to make. There isn't a lot of diversity within the donor sperm and certainly not donor egg pool. But it's quite an interesting thing to undergo anyway, whether you're whether you're going through the solo. I've put this for single parents too, whether you're solo or in a same-sex relationship, because you can look at many different aspects of that individual. You can look at their height, their ethnicity, hair color, eye color. Very often they'll give you a recording of their voice. You can get a handwritten letter from them. You can very often see a picture of them as a child. So that decision is quite a difficult one, but many times people will look to essentially get enough of that same donor once they've decided, so that subsequent children of theirs can have a sibling match, essentially. So what you have to remember is within the UK anyway, donation is not anonymous. So anything after 2006, there used to be donor anonymity. And that was actually quite interesting, a little bit crazy, because so many men would just go donate their sperm and they would get a fiver for it and they'd come back and that would be that, continue on their lives. And then the law changed to essentially say that you could not donate your sperm anonymously, that you had to consent to being to essentially disclosure of your genetic origin. And so now any of the sperm that you get within the UK is the child will have a right to essentially look that person up and contact them. Now, they may never respond, but they do have that legal right now to contact the donor, whether it's sperm or egg, when they are 18. So a third of sperm is imported. So a lot of it comes from Denmark, the US, but one person's sperm can actually be used for up to 10 families, which is quite a lot. Although if we look at Genghis Khan, I think he impregnated a lot of people. So maybe it's quite limited in today's society, but it's an interesting fact nonetheless. And then just signposting some of the support you might need. We do recommend that people are really prepped and are at least aware of fertility counselling and advice, because it can take quite a toll. Hopefully going through this, and especially going through our guide, I really do think forewarned is forearmed. When you know what you're about to receive, it's much easier to navigate that journey than a lot of people who go into it quite blind, and then they're thrown terminology, they're thrown acronyms like IVF or IUI. I'm going to explain them in a minute. They're thrown a very expensive treatment, coupled with having to miss work, coupled with having to face possibly failed transfers and pregnancy loss. It can be quite difficult. So knowing the stats is also something that's really important to know. So looking at some of the numbers, actually, I did mention 1 in 6 experience fertility issues, but in terms of NHS funding, about 32 heterosexual cycles were funded by the NHS. There have been around 69,000 IVF cycles in the UK in 2019. There are around 5,700 donor insemination cycles. The cost is around 5,000 per cycle in a private clinic. And the success rate, though I caveat this hugely, is around 24% live birth rate per cycle. And I really do caveat that people always look for a success rate, and the success rate is very different per individual. To me, asking what my success is through a round of fertility treatment is like somebody asking me, what are my chances of getting better if I'm sick? You would say, firstly, what age are you? What's wrong with you? Have you any family history? Have you any comorbidities? And I think so many different factors must be taken into account when it comes to overall success rates. So I'm going to start with intrauterine insemination. So I mentioned at the beginning, obvious't it takes a sperm and an egg. The lowest friction, or the easiest, not easiest is the wrong word. Forgive me, I'm grappling with words here, but essentially, if you want to get pregnant, in a same-sex relationship, and you don't want to go through egg freezing or can't afford it, essentially you need to get pregnant, and what you need is sperm. And so one way of doing that is through intrauterine insemination. You are inseminating, putting semen in, into your uterus, so intrauterine insemination. And so it typically involves direct transfer of either fresh or frozen sperm. It will be frozen. It's not still frozen, it's frozen and thawed. It will all donor sperm that you get has been frozen and transferred to where it is, thawed, and then it's transferred or used to fertilize an egg in the dish. So this is obviously done in synchrony with ovulation, as I mentioned, and it can be either stimulated. So in other words, what you're doing is you're using fertility drugs to improve your chances of ovulation, or unstimulated. In other words, we're just putting the sperm in when you are ovulating. So it's good for using donor sperm, or single women. It's often used if you have HIV, or if you have, or if you your partner obviously wouldn't want to have intercourse. It's not recommended, however, if you have low ovarian reserve. Intrauterine insemination is expensive, so if you have low ovarian reserve, trying to do that is your chances are lowered. It's not recommended if you have mild endometriosis. The last 2 points don't matter. Okay, so then this I've purposely left in the page number here. This is on page 33 of the guide. So what I'm going to do is I'm just going to walk you through this guide. The steps that I've already mentioned are step 1, and check in on your fertility. Step 2 is going to be a stimulation cycle, or there may not be if you're going to do if you're just going to harness your normal ovulation. Step 3 are going to be ultrasound scans to make sure that there are plenty of eggs. Step 4 is through ovulation, and then step is essentially waiting until you're ovulating. So again, we have both scenarios listed here. One is in a natural cycle when you are not using drugs, and the other is and there are so many ways that you can tell when you're ovulating, really by honing in on that cervical mucus. I am at 1 with my mucus, and it's amazing to me that I know exactly when I've literally ovulated, because the mucus almost turns to liquid. It's like when you crack an egg, and actually it physically feels like that sometimes, an egg being cracked, because you can get ovulation pain, where sometimes you're like, oh, what is that? And it alternates every cycle, one month to the next. And that pain is literally the follicle bursting and the egg releasing. And so your cervical mucus is it's like an egg yolk at that time. And kind of tapping into that to me is like, I am my own experiment. But that to me is one of the best ways of understanding when you're ovulating. Step 5 is the insemination part. So the donor sperm, if you're using donor sperm, will have been thawed, and it will be loaded into a catheter, and then a long needle will be put up into the uterus essentially, and a syringe pushes it in there. Now, back in the olden days, they used to use a turkey baster, quite literally what they used to use to baste turkeys. I'm not being crude. I'm simply stating that actually there are cheaper ways of doing this, especially if you were going to using a friend or somebody that you knew. Or you could probably get one of these insemination needles. I think in Germany, when you go for these treatments, they make you buy the needle themselves. They told me that yesterday. You have to arrive with your own big catheter and needle. And then obviously the big step is waiting 2 weeks to do a pregnancy test to see whether you are pregnant or not. The next version, or the next step up from this, is IVF. Now, what this will involve is a whole other side of things, and that is retrieval of eggs and trying to get more than just one egg. In the former cycle, we're just essentially waiting for one egg to be released, or 2 if you hyperovulate. But in this instance, what we're doing is we're actually saying, and sometimes this is both of you will go through this, or at least one step of this. So when you go through in vitro fertilization, it still relies on you getting eggs out of the body. So this will rely on, number 1, the check-in on your fertility, which you'll have done. Based on the level of your hormones, then your stimulation cycle. So we're essentially stimulating, I mentioned all the follicles in your eggs or in your ovaries. Only one of them will be released any given month. However, in an IVF cycle, or a stimulation cycle for egg freezing, what we're doing is we're giving you enough of those hormones that would be in a normal menstrual cycle, but so many of them that we mature as many of those eggs as possible. The idea being that you're essentially, it's like ovulation times 10 if we can, but instead of your eggs releasing all of those, or your ovaries releasing all of those, what will happen is when you go through the series of, you'll take the medication, which I will warn you or mention is you will inject yourself every day until the eggs have matured enough, and then you'll be given a hormone known as a trigger, essentially known as a trigger injection to help the eggs fully mature, and then you go in and you have your egg retrieval. So essentially, when you're given, when you're going through that stimulation cycle, you're given all the drugs, you come home. That sounds like a great party, but you're given this box full of essentially hormones that you'll have to inject. So look after each other, do it for each other. If you have needle phobia, just you can take turns, you can watch videos just to prepare yourself on it. And then when you are ready for that egg retrieval, you will go in. It's honestly no more than about 30 minutes. You'll be mildly sedated, legs in stirrups, and they will go in and they will put in this catheter and needle, and it will go through the wall of the uterus up into the ovaries, and we're aspirating. In other words, we're trying to retrieve as many eggs as possible. Being in the lab, that is the most kind of monumental moment, really, because as that's happening, you're filling up a vial and they're passing it through the hatch to the embryologist, who's counting the number of eggs that you get. So you just hear the dish being to come into the lab, and they'll look and they'll say how many eggs, and they're counting. Then they might say none, 1, 3, 4, and it's kind of a tense moment, I think, for everybody there, because they're going to see how many eggs that you have, and those eggs are then going to be used for fertilization. So then, while this is happening, if you're going to go straight through this process, you'll be preparing, or the lab will prepare the sperm. So there's 2 ways for fertilization to occur. Either you take one of those eggs and you put you put kind of an ejaculate around it. So you put all the sperm around it, and one of those sperm will fertilize the egg, so the best sperm wins. Or you will have a process where, and very often the second part, this one is done instead, where they actually inject the sperm, as you can see from this little infographic here. You inject the sperm into the egg to fertilize it, and that's called intracytoplasmic sperm injection. So you're injecting the sperm into the cytoplasm, or ICSI. So those are your 2 fertilization options. Once fertilization has occurred, that embryo then will develop. So it will essentially, as soon as fertilization occurs, it is called a zygote, which is a 1-cell embryo, and it divides and divides and divides and divides and divides. And so you'll be able to, some places will allow you to have time-lapse imaging, and time-lapse imaging is when you can actually watch the progression, or have literal videos of those embryos growing and dividing until they're ready for transfer. So you, depending on the number of embryos that you have, that develop to day 5. So typically they are growing for 5 days, 3 to 5 days. So you can check in on the 3rd and the 5th day. But on the 5th day is when you essentially would decide which one to transfer. It might be that you have none to transfer. It might be that you have only one to transfer. It might be that you have plenty, and they choose which one is best, and they transfer that one, and the rest are frozen for any further cycles. And then following the transfer, we hope that that embryo will implant. And then again, you're going to be looking for HCG, which is a pregnancy test, to confirm that pregnancy. I'm aware there's a lot of details here. It's why we created the guide. It's why we're actually not just doing the guide, but also doing this webinar, because sometimes it just, I don't know, it helps to go through things. But I want you to know that we are here, and we have a very, very dedicated team of people who are here to answer any questions should you need it. So then the egg freezing pathway pretty much mimics all of this that we've already spoken about. You'll do the consultation and fertility test, deciding if you want to egg freeze, or if both of you want to go through this for another time. You'll do the ovarian stimulation. You'll then do the egg retrieval. We've discussed all of these points up to here, egg retrieval, and in the former image, we fertilize those eggs. But in an egg freezing cycle, you'd retrieve the eggs and they would be frozen or vitrified, which is like they're flash frozen at 196 degrees liquid nitrogen. Okay, so eligibility on the NHS is a big problem, because we know that the majority of care commissioning groups do not actually you're not eligible, certainly as a same-sex couple. I just put that in there. We looked at our data to see how many people would ever have been eligible. Heterosexual individuals, how many would ever have been eligible, and 70% would never have been eligible, and yet they're told to wait for a very long time. And for same-sex individuals, we know that this is, and we've explained a lot about this in the report about the individual care commissioning groups, which require you to have multiple rounds of intrauterine insemination, which is expensive, before you can go through IVF. So it assumes that you're fertile before you go on this journey. And I didn't want anyone to assume they're fertile before going on this journey, because you might not be. But regardless, doing intrauterine insemination, when we look at the dichotomy of scenarios, when you define infertility, and you say that actually infertility is defined as a disease of an inability to conceive after 12 months of regular intercourse, the reason it's 12 months is because sometimes it takes 1, 2, 3, 4, 5, anything up to 12 for people to get pregnant. So if you were expecting somebody to pay for that off chance, so like, let's do it 6 to 12 months, it's unbelievably unfair that we would say, well, you guys have to pay for it. So we know there are inequalities. We actually are working really hard so that we can change that. The other options in terms of these processes, and it's good to have a conversation about this, are shared motherhood. So this is either intra-partner egg donation. So you'd both go through egg freezing. You'd both get maybe the same donor sperm, and you would fertilize each of your own eggs, and then you'd swap. So you would carry each of them. Some people do this so that that there isn't almost, for want of a better word, favoritism, that they're growing their own egg, but actually that does come with much higher risk and immune rejection. So it's worthwhile bearing that in mind. It's also worthwhile bearing in mind that it's exceptionally expensive to do that. While it seems like the dream scenario, I do think it's worthwhile having a very frank conversation. And I'm being very frank about this as well, because I know many people have gone through this journey and have said, why didn't I just do IUI of my own? I wasn't experiencing infertility. I wish I just did IUI. I would have at least maybe gotten pregnant instead of going through stimulation, egg freezing, fertility, on both of them, and swapping. It's an expensive option. Another option, again, is co-parenting. So that would essentially mean that you would decide to go through a co-parenting journey with another individual and bring up that child together. And then I'm going to mention adoption, because it is really important that people know that all of the different options available to them if assisted reproduction isn't successful, or it's not something that you actually that sounds too appealing to either of you. So adopters become the legal parents with the same rights and responsibilities as the child that was born to them, if the child was born to them. And then I'm going to mention surrogacy. I know this is for same-sex couples, but essentially it's also for people with a medical condition where essentially you may be born without a uterus, as people with MRKH are, or you might have had surgery, or you might have a condition which means that you can't carry a pregnancy yourself. So it's important so surrogacy involves either using your own eggs or donor eggs, plus a sperm, and a surrogate mother carrying it. So this individual will actually be the gestational mother of that baby. Commercial surrogacy is illegal. Commercial surrogacy is essentially when you pay someone to do this. You could only do it altruistically. So very often it's family members. And that's why I want to get to the next part, is oftentimes people will go what we call cross-border reproductive care, and that is that they travel for fertility treatment. The main reason people travel for fertility treatment is that the waiting lists are too long, they're not eligible, it's more expensive in their home country, and so it is worth mentioning, though I don't recommend because it's quite difficult to travel as well. But the options are there, and there are a number of programs that really do assist with cross-border reproductive care. I'm going to mention transitioning as well, because it's really important to note that for individuals who are thinking about transitioning, and one of the case studies that we have is a wonderful human who essentially wanted to transition, but also wanted to have a family. And that was a very difficult time for them, because they obviously were kind of through this decision to take exogenous hormones to begin that transitioning. But then what you're doing is essentially the extreme opposite when you go through a stimulation cycle, which is pumping yourself full of other hormone, the opposite hormones that you actually wanted for that transition journey. But it is important to remember that it does give you options if you are to preserve your fertility prior to transitioning. So I would recommend that people do really look into preserving your fertility before undergoing gender confirming surgery. Now, the cost of treatment does vary. It really does add up. And I think that is something that is really important for us to just be open and frank about. We have an egg freezing journey and an IVF journey. So if you're going through this journey, please let us bring you with us, or please let us bring you through that journey. We've really built everything so that we can essentially hold your hand going through it and be there for you, so that you're not left with the confusion of all of the additional tests that you might be offered. The tests that you might be offered are called IVF add-ons. A really great website that's very informative outside of fertility is the HFEA, which is the Human Fertilization and Embryology Authority. That is the governing body that resides over all procurement and storage of gametes, all fertility treatment in the UK. So if you are a clinic, you have to have a HFEA license or you will be shut down. But essentially the HFEA were quite clever in putting in a traffic light system. And this is essentially a color coding for the different treatments additional to the ones that you may need. So they're going to be the ones that are no choice in, but there are additional things like time-lapse, being offered time-lapse. It's an additional cost, and though it's cool to watch your embryos grow, if you can't afford it, it's not going to increase your chances of having a baby. And there are other kind of unproven treatments that you might be offered, like endometrial scratching, to look at the receptivity of your uterus. They aren't actually proven to increase your chances as well, and are expensive. And then anything that is in red is essentially that there's no good evidence and shouldn't be offered. So just be wary of that and have a look at the HFEA traffic light system, so that you're essentially going in really prepared to your to a consultation at an IVF clinic. But again, we're going to give you all of the highs and lows. And I want to just finish on the emotional impact, because it is quite serious. This is such an amazing thing to be able to go through together. And I said at the start, forewarned is forearmed. When you are taking exogenous hormones, when you are under financial stress and pressure, when you are under physiological pressure, it can take its toll. So a study showed that 90% of people going through fertility treatment feel depressed, 50% feel helpless, out of control, fearful, and worried, and actually 42% experience suicidal thoughts. And I know that's a very dark thing to end on, or highlight. The reason I say so is that if we are aware of this going into it, we can really arm ourselves with a better support network. And I think that's something that we can be there for each other, whether it's through counseling and therapy or support for one another. But it also just sheds a light on something that actually we just need to address. Without addressing this, people do go in a little bit blind, and it can be, to me, the fact that 50% feel helpless and out of control is because they don't know what they're going through. And that's why we feel so strongly about kind of the hand-holding part of what we've built. I mentioned at the start, if your workforce isn't a supportive employer, please let us know. Please let them know. You will inevitably, if you're working, go through a lot of this from home, and it might be that you just want to signpost to them. If they should have policies, and if they don't, we have policies that they should have that essentially say that during this process you should be able to work flexibly and just have a bit of an internal network. So I'm going to stop there and take time for some questions. If you have any, please do have a look at the guide and just take your time with it, read some of the stories, know that we're here, and thank you for spending your Thursday evening with me tonight. Okay. Okay, somebody's asked if it's recorded. Yes, it is. And how much does, oh, wait, hang on. If you're overweight, does it affect your fertility? And funnily enough, a lot of clinics won't accept people over a certain BMI. The partner clinic that we work with at Fertility will accept over a certain BMI. The guidelines are really changing. The reason weight can affect fertility is because essentially it throws off our metabolism for ovulation. And so a higher weight increases pregnancy complications generally, but higher weight can also reduce our ability to ovulate. So it's not, but knowing whether that is a metabolic weight gain is actually is a really important step. So but there are different guidelines related to that. There's a really amazing I can't remember the name of her page, Sugar. I'm gonna try and send it afterwards. It's somebody who's got an amazing Instagram page, and she gives a lot of support for people with larger bodies, and she's quite cool. Then how much do each of the treatments cost? So the intrauterine insemination, I think, is around £600, but bear in mind it has to be taken with the cost of donor sperm, and when you're looking for donor sperm, I'm literally looking it up now because I don't want to quote you an incorrect one. I should have known before, but it's actually quite different per clinic. So the reason I want to look at the first sperm is that while it might seem that you would want one vial, actually some people want many different vials because, as I mentioned, depending on the number of siblings that you want. So I'm just looking at the London Sperm Bank here. There are many different banks, but one vial is around 1,100 for IVF and ICSI. Intracervical insemination, one vial again 1,300, and one vial for intrauterine insemination is 1,480. So that's an additional cost that we have to take into account, but very often the clinic will lump those together. Oh my God, loads more questions have come through. Do you offer a pathway for same-sex couples? Yes, we do. 600 of you have logged up or have downloaded our guide. A huge number of you have opted in. When you look at the guide, I'm going to try and send it in the chat, the link for the guide now. Let me stop sharing. And I'm going to send the link for the page now in the guide, because in that you'll be able to see that you can join the wait list, you can join our list to become part of our beta trial users for bringing you through this journey. So definitely come and join us through that journey for that pathway. While I'm doing that, somebody said, just wondering about the IVF procedure, inserting sperm versus putting it around the egg. Does it make it more likely for the fetus to have abnormalities versus naturally the strongest sperm would get through the egg? Just curious. It's a great question. Intuitively, you would say that, may the best sperm win. I think I did say that, but we don't see any difference in outcomes. The reason clinics actually do ICSI is that you have a higher chance of fertilization. It's kind of a brute force. In truth, we shouldn't do ICSI in the absence of a medical reason. Like, ICSI was only ever invented for male factor infertility, but no, it doesn't actually lead to higher number of abnormalities. We have quite a bit of data on that. There's a question: does Hertility have any plans to link to accounts that have done fertility screening and offer consultation as a lesbian couple? Absolutely. In the first instance, we won't be able to link the two accounts because we couldn't do that for GDPR reasons. Like, we wouldn't ever combine two people's medical histories. What your medical history is very private to you, and there are laws around us sharing medical information. However, the consultation would involve both of you on that call. There's a question asking, do we offer sex selection too? I presume you mean sex selection of the embryo. No, sex selection is illegal because of the very dark history with many different cultures only wanting to select male, who not anymore. is it possible to reserve sperm so it cannot be used by multiple families? And when you look on that, you'll see how many families have already used it. And so you could technically buy up the rest, but there's nothing to stop that individual donating again. So it's hard to protect that sperm essentially and keep it for yourself. Somebody said, thank you so much for this. First time in a long time I felt hopeful that it might be possible to get answers about my symptoms without getting turned away and gaslit. Could you expand a little as to why IUI isn't appropriate for people with mild endometriosis? Absolutely. I will say our test does screen for 18 of the most common gynecological pathologies. We've worked very hard to make sure we actually include as many different risk factors as possible in that health assessment and the tailored test. The reason we don't necessarily say that it's appropriate is that what you are doing is you are putting it's purely to do with success rates. And again, I did already say that is caveated with the individual, your age, your egg quality. I think it's to do with more of a cost success ratio, because you have mild endometriosis. Doing intrauterine putting the sperm into your uterus, if you have endometrial and endometriosis, your receptivity just might not be as good. So next question, I hope that answered that. What can you do on a daily basis to increase fertility chances? The best thing you can do really is all in your preconception care. So within the guide, you'll see, I'll tell you the exact page of the guide. I won't be able to tell you the exact page of the guide. I'll try and do it. But in the guide, we do have fertility or nutrition for fertility. And that is such a really amazing guide as to the things that you should be putting in your body. Preconception care involves more fiber, more fruit, more veg. It sounds so obvious, but your body really does need all of these things. Taking some prenatals like folic acid, not too many. A lot of people combine them and they take far too much folic acid. Making sure that you have high iron. There's anecdotal evidence that individuals who are vegetarian or vegan in particular, who don't get proper animal fat, can't synthesize as much estrogen. We're going to do a research study on that to make sure that we see a little bit more data on that, but it's worth bearing in mind if you're struggling. There's a lot more questions, so I'm going to try and get through them until 8 o'clock. One has said, how much would it cost to have my partner's egg fertilized and implanted into me? Let's break down the costs. So you're talking at around 1,000 for the sperm. Your partner's egg would be fertilized through a round of essentially egg freezing and fertilization. So it's around 5,000. So now we're at 6,000 for the egg freezing. The fertilization, essentially you're going through autologous IVF. I would say between 6 to 7 or 8,000 pounds to have your partner's egg fertilized and implanted into you. That's if it works the first time around. So I hope one day we can find a way to make this more affordable. Watch this space. You'll be watching for a long time, but if there's anything I can do to make this a more affordable space, I will. And that's what we've done with Hertility already with the first step. I'm just going to see, is there anything else that might be beneficial to anyone else? This is amazing. Thank you. Thank you for the webinar. So there's 2 questions here on endometriosis, controlled hormone therapy for 6 years. We have one of the most world-leading experts in endometriosis and on our clinical team. So next month, we're going to be doing a webinar on endometriosis and fertility. So I'd actually, rather than answering for him, I am a molecular geneticist. I am not an obstetrician gynecologist, and I would love for you to join us in our webinar on endometriosis and fertility, where we can actually get to some of those questions. So if you'll bear with, we're going to take all of these questions, and if you're happy for me to come back to you personally on that question, I will do. But you've asked about the success with people with endometriosis, and I think that would really depend on the stage and the grade or severity of endometriosis. So actually, I've got your name, and I'm going to come back to you personally on that. Okay, I'm trying to get through some of the questions with a lot of it. Thank you. Thank you. The last question is around health risks, around doing IVF treatment. Yes, of course, there are health risks with any procedure, especially one that involves giving you exogenous hormones. The most frequent, but less so nowadays, is ovarian hyperstimulation, where essentially you react too much to the stimulation protocol. That can come across, it can start with like bloating, and then it can be very extreme. Ovarian hyperstimulation syndrome is much less now because we monitor your hormones. So we'd see that they were going up, and they'd actually stop the cycle so that wouldn't progress. It used to be a much more serious problem. It says, if you have PCOS, are you still able to donate an egg to your partner? Yes, if you have PCOS, you can still go through an egg freezing cycle, and we look at the health of those eggs. And yeah, you could still donate them to your partner. Absolutely. Okay, that's it. There's a few thank yous coming in, and I'm going to leave it at that. Thank you so much for joining me, and please do download the guide. Please do go through the journey with us. And if you have any questions, just get in touch. Thank you so much for joining us, and happy Pride Month. It was raining this evening and sunny, so I actually was looking for rainbows. I thought it was very, very telling of the evening. All right, take care of yourselves, guys, and thank you so much for joining me.